I'm happy that you could join us today for this Learn at Work webinar presented by the journal Work, a journal of prevention, assessment, and rehabilitation. I'm Karen Jacobs. I'm the founding editor of Work, and I want to do a shout out to iOS Press, the publisher of Work, who supports this webinar. It's with great pleasure that we have our speaker today, Caitlin. And Caitlin will give you some background about herself first and then provide a very interesting webinar. So, Caitlin, I'm going to turn it over to you.
Great, thank you, Karen, and welcome everyone. I'm so glad that you are able to join us here today. I'm going to be talking through a program that was published in the Work Journal in, I believe, in spring, maybe March of this year in the Work Journal. And the journal or the article title was Addressing Brain Injury in Healthcare for the Homeless Settings, a pilot model for provider training. So I'm going to be talking through that today, which is an exciting program that I really enjoyed doing. So I'm excited to share that with you today. So just a little bit of background on myself. Like Karen said, my name is Caitlin. I'm an occupational therapist. My primary clinical experience has been working in mental health and then specifically with a population of adults experiencing homelessness. And it's with working that population that really I transitioned from being sort of a true mental health provider per se, more to a generalist and occupational therapist, really encompassing whole person care. And that's primarily because the population of people experiencing homelessness have so many comorbidities and significant needs. And there's some new knowledge about the impact of TBI on this community. And so really addressing all of those different factors influencing their ability to engage really healthily in their communities and the way that they desire. I've since recently transitioned from being in direct clinical care. I'm now working for the National Healthcare for the Homeless Council as the program manager for their medical respite programs to support expansion and best practices in medical respite care. So I'm excited to be here talking sort of about direct clinical care and program development, which are my two major focuses of practice. So to give an introduction, I'm going to kind of relate brain injury and homelessness. And part of this is the need to do this is that up until maybe, within the past 10 years, maybe even less than that, there's really been a recent understanding of the prevalence of brain injury in this population. And prior to that, it really wasn't anything that was known, that wasn't documented, that wasn't well explored. But since then, there's been an explosion of research looking at sort of the incidence and prevalence and relating factors in this population that have really brought about some key findings that are important to consider working, either if you're working with folks with brain injury or people experiencing homelessness or both. And I'm going to point out some of these key highlights, although there's several really great articles referenced here that are worth digging into if you're interested. But some of the key findings are that there's up to 50% of people experiencing homelessness have sustained a TBI, which compared to the general population is about 5 times greater, which is a pretty significant amount higher. They've also noted that there's a high correlation of mental health symptoms and a history of TBI in this population. Another really interesting and key fact that I like to bring up is that 50 to 90% of people experienced their first TBI before they became homeless or moving into marginal housing. And that's really important to consider more in the brain injury world as how TBI might be playing a role as a risk factor for homelessness. And when they sort of dug into more about the folks who'd screened positive for a TBI, they found about 25% of them have sustained a moderate to severe TBI, which we know relates to experiencing more difficulties or impairments later on. Additionally, what they found is that 5 to 15% of the mild TBI survivors, so not the moderate or severe, have semi-permanent or permanent deficits that can impact their performance in routine activities. And one key area of impact is cognition, and a different study that looked not so much specifically at TBI, but at the frequency of cognitive impairment found that the rate was 25% in adults experiencing homelessness. And these numbers we are guessing in the field are somewhat low because a lot of the studies don't use consistent methodology to assess for cognitive impairment, and it's not necessarily always a true large sample. And so 25% is a high amount anyways, but likely it's a low number, a low figure when we consider in if 50% of people have a TBI and a moderate to severe TBI, the likelihood of cognitive impairment is increased in that. And similar to TBI, another study found that cognitive impairment is both a risk factor and a perpetuator of homelessness. And I'm going to talk through that a little bit more in a couple of slides here. And then another study in relating brain injury and homelessness to mental health symptoms found that there was increased odds of a TBI with loss of consciousness were associated with mental health symptoms, a history of suicide or attempts, having migraines and epilepsy, and this is specifically in a population of adults experiencing homelessness. And then greater when we're thinking more about the social determinants of health, a history of TBI with a loss of consciousness, people were more likely to have been in contact with the criminal justice system, were more likely to be high utilizers of the ER, and really interestingly, more likely to report unmet healthcare needs, which someone working with folks with TBI might not be surprised about this because there's so many things that can be affected after a brain injury that would require or have a person seek out needing medical care. There's a lot to manage that can happen after that. And so following TBI, there's so common cognitive impairments such as poor concentration, decreased attention, memory difficulties, impaired judgment, difficulty following instructions due to executive functioning issues. And often these cognitive deficits can be associated with poor functional outcomes in social interaction, problem solving, building and learning new skills, general occupational performance, and independent living. Now, I will put a caveat here that cognitive impairment is not a predictor of a person's ability to live independently in the community, but it is definitely a factor and a reason why people have difficulty transitioning out of homelessness into housing. So there's definitely a difference between cognitive performance and functional performance, but we really do need to consider how these cognitive deficits in contexts that are not supportive can exacerbate their impact on function. So in addition to potential functional difficulties, studies also show that a history of TBI can be associated with increased vulnerability for poor mental health. So folks can experience higher rates of generalized anxiety disorder, post-traumatic stress disorder, which may be related to the circumstances surrounding the TBI and assault itself, major depression, poor affect, and suicidal ideation. And so putting this in the context with the mental health issues helps to sort of support why this program, this pilot program to training providers was established, because it focused primarily on social workers and mental health providers. And this is, people would often present for behavioral health services as a result of these symptoms, these mental health symptoms, feeling anxious, PTSD, depressive symptoms, and really underlying some of that is this TBI, and not addressing some of the effects of the TBI was impacting the mental health care, people's ability to progress in their mental health treatment plan. So this overlap is really why we targeted the providers that we did in the pilot study. So just thinking generally of the context in which people who are experiencing homelessness live, an undiagnosed or untreated TBI can really impact the ability to prevent homelessness, especially people who are living in poverty, who have lower incomes, who have less support systems, who don't really have that caregiver support that can be common, that we sort of utilize in rehabilitation programs. And it can make it much, much harder to move out of homelessness because folks have difficulty navigating complex resource systems. Even as a educated healthcare provider who's worked sort of in this area of practice for a long time, the housing process, the SSI process is still kind of daunting and overwhelming, right? We have specialists that really focus on navigating this. So for the general person, it's difficult, but adding in someone who's dealing with cognitive and mental health effects of TBI can be even harder. Additionally, when people are living in shelter or transitional programs or recovery programs, folks with TBI are going to have a harder time remembering what the shelter rules are, following these rules. They often get deemed non-compliant or behavioral issues or difficult or stubborn, when really these behaviors are a result of not understanding or not being able to remember, and are not really malicious or intentional, but more of a result of how the brain is working as a result of TBI. But unfortunately, in some circumstances, this can result in them losing their bed, losing their spot at programs, not being able to progress through the treatment plan because it's so focused on behavior management, they never get to the part of looking for housing or accessing resources. And then also difficulty anticipating problems and not necessarily being able to think about different outcomes of different actions. And that, again, moving out of homelessness requires a lot of complicated steps, can be really hard to navigate. And in some cases, people are just making really difficult decisions between basic safety and health needs versus these more complex long-term goals. And it's hard to identify why working towards those long-term things might be important when I'm hungry now, I need shelter now. And so all of this context and this data that we knew at Healthcare for the Homeless led to wanting to really provide a way for mental health providers and behavioral health providers to be able to address TBI within their practice. And there's a few pieces of rationale behind that. Part of it is that most of the time, especially with people experiencing homelessness, providers are unaware that there is a history of brain injury. And even if they do know that there's a history of brain injury, they don't feel equipped to address brain injury or to address the effects of that. They feel really confident, perhaps, in providing mental health care, but don't know what to do when the TBI is complicating. But not addressing this can impact the person's ability to engage in services or might limit the effectiveness of the services that they're offered because it's not navigating around what their needs are for learning. Additionally, what we find in terms of TBI rehabilitation and strategies for that is that these are often really reliant on the presence of caregivers or on resources to be able to purchase and use certain types of technology, to be able to navigate certain systems, to just sort of accomplish all kinds of things. And people who are living in poverty or who don't have support systems that have the resources to take care of them, a lot of these strategies are not as effective. They're not developed for them. And so you can't necessarily take a specific rehabilitation approach and apply it in this setting. It needs to be modified and adapted. And so in doing that, sort of this program intended to make a marriage of that, taking evidence-based strategies, but tailoring them to the needs of this particular population. And in doing that, we had to consider a couple of different things, especially the things that might be impacting cognition. And so cognition was a major focus of this particular pilot program. So in addition to TBI, people experiencing homelessness often have other factors impacting cognition, which could include the presence of a developmental disability, HIV, substance use, both a history of or engaging actively in substance use, a serious mental illness and mental health diagnosis, especially if somebody's symptoms are more active at the time. So an acute depressive episode is going to impact cognition. If the person's had any other sort of medical intervention or recently been in the ICU and is managing other chronic conditions. So for example, recent studies have found that people even in middle-aged, the general population who have diabetes, there's cognitive impacts at middle age and not just as older adults. And folks experiencing homelessness have a high rate of diabetes, hypertension, and these other factors that might impact cognition. In addition to all of these sort of medical conditions, people experiencing homelessness really have a lot of impact of environmental factors impacting cognition. So not having safe or stable housing, that sort of extra level of stress and insecurity for the day makes it really hard to focus on things. Poor nutrition and lack of access to food impacts our brain's ability to function well. Sleep deprivation, which may be a result of trauma, may be a result of living in the shelter or on the streets. I know personally I don't do well without a lot of sleep, and so I can't imagine sort of over an extended period of time, we have to consider how that's gonna affect somebody's ability to focus and use cognitive skills. We also know that trauma and chronic trauma can have an impact on cognition, as well as an acute stress stressor or stressful event. And we also need to consider literacy and lower literacy levels among this population. To give you a little bit of background on the setting where this pilot study was completed, the setting was Healthcare for the Homeless in Baltimore, Maryland, and Healthcare for the Homeless sites. There's over 300 Healthcare for the Homeless sites across the country in different communities. But the goal of HCH sites is to increase access to primary care and also provide wraparound support services to address health and housing needs. And healthcare for the homeless services are different than what you might find in your typical primary care. The goal is that they're flexible in service delivery, they have outreach, they include interdisciplinary and integrated care, addressing social needs and enabling services, and support access to other priority medical care, such as helping navigate systems to see specialists and things like that. And another really important key feature is the inclusion of consumer advisory boards at each healthcare for the homeless site. So consumers and people who are receiving care at that site are part of the board to help inform programs and HCH development. So the HCH site in Baltimore is considered a federally qualified health center and a healthcare for the homeless site. This specific clinic provides comprehensive integrated care for persons experiencing homelessness, and at this site is able to offer primary medical care, behavioral health care, substance use treatment, case management, supportive housing, occupational therapy, dental services, and benefits acquisition. So navigating to apply for SSI or insurance coverage through Medicaid, Medicare, et cetera. So really comprehensive interdisciplinary care offered at this site. And so I'm going to talk through now really what sort of the specifics of the provider training was. And so like I said, it was targeted specifically to behavioral health providers, and these providers could have been working on the mental health team, so providing therapy in the clinic setting, or part of the supportive housing team where they operate as therapist case managers. So their roles are a little different. They do provide therapy, but also additional case management for people who are living in the community in supportive housing units. So what our training included was we trained providers on the Ohio State University TBI identification brain injury screening. We also provided training on the World Health Organization Disability Assessment Scale version 2.0. We provided education on using SMART goals to inform treatment planning. And then we also, really the meat of the training focused on learning more about cognitive deficits and related strategies to address these deficits. And these were based off of compensatory strategies from the rehabilitation world, and also integrating mental health models that were familiar to the providers. This was done over 8 sessions that occurred over an 8-month period. So they happened about every 3 to 4 weeks over this 6-month time. So the 2 initial training sessions occurred, which sort of oriented folks to the training and provided education on the different screenings and the SMART goals. And then there were 6 didactic sessions, which included an overview of a specific area of cognition, internal and external strategies that could be used, case applications, and overall discussion. So trying to provide a few different methods for learning and a way to really apply the content to clients that the providers were working with directly. So just a background on what the brain injury screening is, the OSU TBI ID is the shorthand name for it. It's a short structured interview used to identify a history of TBI, and it's very useful in working with more underserved populations or where TBI is probably not known to providers, because it helps determine TBIs that maybe were undiagnosed. Often people maybe experience a TBI but don't seek care for it, or that it happened remotely and it's, since the person is engaged in care, it's not known that it's there. It's a really great tool because it was actually a valid and reliable measure, but it was tested on populations of people experiencing homelessness, those leaving incarceration, sort of more these underserved and more at-risk and vulnerable communities that are not necessarily targeted when tools and measures are developed. And it's an interview that, instead of asking do you have a TBI or have you ever had a TBI, asks in terminology familiar to the client, saying, have you ever had an injury to your head or neck? Have you ever passed out or lost consciousness due to a fall? So the formula of the questions really is more conversational and can help identify the history of the brain injury. Because if you ask people, have you had a TBI? They may answer no because they don't think what happened was a TBI, or they don't remember that, but they'll remember a certain event that happened. And the OSU TBI ID is scored in two ways. The first is it identifies the type of injury that occurred. So the worst, first, multiple, recent, or other. So how severe was the TBI? Did it happen before the age of 15? Were there multiple TBIs close together? Was there one that happened within the last few weeks or last months, or sort of combined with any other way that their brain function has been impaired? So in this population, that might be having experienced an overdose, which obviously would have impact brain function, but it's not necessarily a TBI, or experiencing frequent seizures, or also having a history of a stroke. So things that may not necessarily come up as a result of the screening, but certainly are going to impact brain and cognitive function. And then the screening tool also has you rate the worst injury on a scale from 1 to 5. So the 1 is, there's not a history of TBI, all the way to a 5 is a TBI that occurred where there was more than 24 hours of loss of consciousness, in the scale in between there. And then the HUDAS 2.0, which is the World Health Organization Disability Assessment Scale, is available for free from the World Health Organization website, and it directly corresponds with the ICF. It provides 36 items. You can do the longer 36-item questionnaire or the short form, which is only 12. And the nice piece of this tool is that the person can fill out the questions themselves, or a clinician can answer on behalf of the person. So it gives you some flexibility in being able to administer it. And what it does is it covers different domains of function, including cognition, mobility, self-care, getting along, life activities, and participation. And we included both of these measures. First, we included the TBI screening to be able to identify folks who had experienced a TBI, so that providers knew when using some of these strategies might be appropriate. We included the HUDAS as a way to sort of inform the goal setting and the treatment planning process, because it allows the person to identify themselves specific areas where they feel like they're not functioning as well. And at the beginning of the training, we were hopeful that we would be able to use this as a pre and post test to see if there were differences in the scores following providers actually implementing the strategies that we presented in the training. So then the first component was also using SMART goals and treatment planning. So within the clinic, providers were responsible for developing a treatment plan when they first started working with the client, and that this treatment plan was updated either at 3 or 6 month intervals. And some of the struggles that the clinicians reported having was that it was hard to identify treatment goals with folks with a history of TBI. Like the persons themselves were not able to really identify achievable goals. And so using the SMART goals, which was actually developed for management in the business world and is really relevant, I think a lot of clinicians will be familiar with this, but it helps to identify goals that are specific, measurable, action-oriented, realistic, and time-sensitive. There's a few variations of what SMART stand for, but this is the general idea. And the idea is that the goal is specific. It's something where you can identify whether or not it was met. So it's clearly kind of a yes or no, did this happen? It's focused on something the person can actually go ahead and do, is realistic, and it establishes a time frame for it to happen. And so we use this to help providers frame their treatment plan to be able to work with clients, whether or not they were using strategies, but to feel like they were progressing more towards treatment plan goals. And then this was probably the hardest part of the whole pilot training, was deciding which cognitive strategies, really areas to focus on and dive into. You could spend probably, 1 6-week session, or one session occurring 6 sessions, there we go, I can say it right. 6 sessions just on each one of these. There's so much information out there, but we attempted to use the ones that we thought were going to provide the most broad sense of skills to the providers to be able to use, and also ones that were more underlying for some of the other strategies and therapies that they might have been presenting. So we focused on building insight and awareness, learning and teaching, building skills for attention, memory, addressing executive function, and communication. The other reason why these were chosen is that they were relevant to the behavioral health providers. So communication and communicating with others, and learning and teaching, building insight and awareness. Those are really critical pieces of what mental health therapy does. But also we selected attention and memory because that is something that comes up so frequently with the clients of reporting difficulty with and wanting help with. So I'm going to talk more about those didactic sessions with teaching the skills and giving some examples of what and how we taught them. So we broke them into external and internal strategies. And so we defined external strategies based on the American Congress of Rehabilitation Medicine's manual, and that strategies that are external to the person, and that the long-term goal is that to enable the individuals to compensate for impairments independently. So really focusing on the use of aids or strategies. So not trying to do cognitive remediation, but really more just developing everyday tools to support the client and whatever their difficulty might be. So we used evidence-based strategies from the Cognitive Rehabilitation Manual, and also influenced by the multi-contextual treatment approach developed by Joan Toglia. But again, like I said, these strategies were then really adapted for the realities of our clinic setting and the situation our clients are living in. And so focusing on developing strategies for self-management, and as a clinic and as a provider, some environmental adaptations that could work with the client as well. So just some examples, and we actually ended up providing a large, about a 20-page handout at the end of it to providers that really detailed these strategies. So this is just a glimpse. There was certainly a lot more, but for building insight and awareness, we encouraged and taught strategies to build a therapeutic alliance, supporting problem solving, helping linking outcomes of actions. For learning and teaching, different ways to help repeat information and breaking tasks down into smaller steps. So we used a lot of methodology from errorless learning and chaining strategies, and helping providers learn how to present and teach information in smaller chunks, and making sure the person could understand and replicate those actions before moving on. In terms of addressing attention, we encourage providers to minimize distractions, having the clients write out the steps that they needed to take, and using that as an external strategy to help guide them through a task. And even just basic things such as using a timer to stay focused on the task, like setting a timer for 10 minutes, and that timer goes off, checking in and saying, am I still thinking about what I'm supposed to be thinking about? Am I still doing what I'm supposed to be doing? Are we still on topic? And building that awareness through the external strategy of a timer. Memory sort of overlaps in a lot of ways with attention and learning, but helping clients develop a system to write down and record information that is useful for them, that is accessible to them, that's within their means. And in some cases, it's using alarms on phones for reminders, and helping people, especially those who are experiencing homelessness, figure out a way to keep important and priority items safe, but also easily findable. If you have all of your items in 4 bags and you have those bags with you all the time, it can start to get really disorganized. And so just being able to identify and find the key pieces of information can make the day easier. Executive functioning, similarly, helping clients determine ways to keep information and things organized with their limited resources, teaching the tasks sequentially, and helping clients prioritize. I think that's really helpful. People have a lot of demands on them and a lot of things that they want to accomplish to move out of their situation, and helping figure out, well, what comes first? What needs to happen before this can happen? And how can we take care of these things? And then with communication, thinking about both, language communication, making sure the client is able to understand and express themselves, but also those social skills of, reading social cues and engaging with others, and allowing time for people to express themselves, especially if there's an expressive language issue there. And then we also paired these with internal strategies. And so internal strategies are those that are more self-generated by the person, and the person themselves is responsible to cue use of these strategies or an action or a sequence. And so internal strategies are certainly much harder, and it would take a client a lot of insight and motivation to start with internal strategies. And so we presented both of these because some clients really could benefit from using compensatory strategies that sort of like meet the immediate need, and then also working on internal strategies so that they can generalize long term. And so in some cases, it was helpful to really pair with the same client, and some folks, just start with the external strategies with the goal of moving to the internal. These strategies were similarly adapted from the Cognitive Rehabilitation Manual and the Multi-Contextual Treatment Approach, but these also really incorporated a lot more of the behavioral health frameworks of CBT, acceptance and commitment therapy, and mindfulness. And so within the pilot program, really focusing these to help clients to develop insight, metacognition, which is sort of your self-assessment of what you're doing, and also addressing those mental health needs, right? So they're coming to their behavioral health provider to work on what's presenting in terms of their mental health concerns. But this was helping providers modify those treatment approaches in a way that was more accessible to people with a traumatic brain injury. So some examples of these for insight and awareness: using motivational interviewing is especially effective, and using the acceptance aspect of ACT to help clients really accept that there may be a limitation, and that might be where some people are, is that, this head injury happened to me, and ever since my memory has been affected, and it's really frustrating, and helping them accept that, yes, my memory doesn't work in the same way, but that is sort of the grounding point to be able to work on using strategies. If you don't accept you have the problem, it's hard to want to use strategies to help it. And also for learning and teaching, this is a good point to transition to that more generalization where the client can self-cue themselves, use the strategies more outside sessions without the provider themselves. And that can be through structured homework or just sort of independently assessing, like, did this happen when the situation presented itself? Attention, it's really great. Actually, mindful meditation is a really great way to build attention skills. And that can be done in a couple ways. One is just sort of to help with grounding, for people to stay engaged or to refocus themselves into the situation. Be done through deep breathing to help manage frustration or to refocus on the task. There's also some great guided meditations and mindful meditation that teach the client to really focus on the experience that they have right now in front of themselves. So leaves on a stream is one example of that. That's one that you can find, sort of that guided meditation, but even just drinking a cup of tea and talking about the sensory experience of that can really build some underlying attentional skills. And then with memory, some folks are really interested in using more like the mnemonic strategies or association, things that are more internal versus writing it down. And then for folks with memory too, it can be really helpful to develop coping to manage the anxiety that comes from not being able to remember information when you want to. And executive functioning, building self-efficacy. Sometimes if people know that they're struggling, their self-esteem can dip because they don't feel like they're as capable to take care of things, being able to accomplish a task. And so that can really help with being motivated to get started on things if you feel like you can do it. Also building cognitive flexibility to be able to respond to situations and problem solve, and using self-talk as a guide when you're doing a task instead of maybe an external checklist. And then communication, really focused on developing insight and awareness of emotions, practicing emotions, what are emotional triggers, all of these things that affect how we engage with others. So again, this was just sort of a sampling of the content that was reviewed in the didactic sessions. This was presented with background information on what is executive functioning, going through what the external strategies were, the internal strategies, and then having the providers talk about, folks that they thought they could use this with, or maybe they've tried it, and what was that experience. So now I'm going to talk about the outcomes. So we were definitely tracking some outcomes from this particular pilot program. The first thing that we looked at using the OSU TBI ID was what was the prevalence of TBI within our particular clinic. So we know that the rates, are about 50% on average in the studies that have been published. So in the period of time during this pilot training, we were able to screen 172 of the clinic's clients. And what we found is that, I'm going to point out a few key features. There's a lot going on in this graph. 117 of those clients had screened for an injury on the OSU TBI at a level 3 worst injury or higher. So that was people had had a TBI with at least some time spent unconscious, whether it was less than 30 minutes or more than 24 hours. So that's a pretty significant number. It's definitely, about 3/4 of the folks that were screened had at least one TBI with a loss of consciousness. What's really interesting is comparing that to the TBI, people who had TBI already identified on their problem list before they were screened. Only 20 of those individuals did the providers know that there was a history of TBI, and it was reflected in their problem list in their medical chart. So that's a pretty big difference. About 90 people were engaging in services with a TBI with loss of consciousness, and we didn't know. So I think that really supports the importance of screening for brain injury, because without doing that screening, we wouldn't have that information, but it was really affecting a high number of people. In terms of types of injuries, so this is not exclusive, so people could have checked yes on the screening for more than one type of injury, but 62 people had an injury before the age of 15. 67 people had experienced a time in their life where they had multiple injuries or repeated injuries, which is not uncommon in a population of people who are more likely to have experienced domestic or interpersonal violence. A small number had recent injuries, which is not necessarily surprising. If they were engaged in care with us and had a recent injury, they were more likely to have had some sort of medical care. And then other, so 94 people screened for an other impact to their injury, to their brain that was not necessarily a TBI. So again, that overdose history or seizure history, other things, conditions that might be affecting that. So in looking at the different types of TBI that was found on the OSU TBI, so 90 of the 172 people, 94 that were screened had a TBI that fell into two of those categories, so the worst, first, multiple, etc. 23 of them fell into 3 categories, 12 of them fell into 4 categories, and there were 4 clients that were screened that actually indicated yes to all 5 categories of the screening. And then we also looked at those with a positive screen. So those who had a positive screen on the OSU TBI-ID, whose worst injury was at a 3, 4, or 5. And we compared that with other co-occurring conditions. So you might see a couple that are sticking out really prominently here. There was a high correlation between folks who had a worst injury and substance use disorder, as well as an affective disorder, which is really interesting and relates to sort of the data that already exists, and that people with an affective disorder or a history of TBI are more likely to have some of those mental health symptoms, especially depressive symptoms. And substance use disorder and history of brain injury is actually fairly well known to be high correlation. And it's sort of a chicken and the egg thing. I think that needs more research, in that there's, is having a substance use disorder, does that put you at higher risk for having a TBI as a result of using substances? Or does it happen for folks that a TBI occurs, and as a result of that brain injury, they're more susceptible to developing a substance use disorder? And the data is not conclusive on this yet, but it is there, and our findings sort of support those theories that are going on. So then we also did Likert surveys of our providers to assess really where they felt they were pre and post doing the training, right? To figure out, was our training effective in the way that we wanted it to be? So the first thing that we looked at was, were the providers comfortable in assessing for a history of brain injury? So the darker blue is pre-training and the greenish blue is post-training. So we definitely saw a shift that by the end of it, providers felt definitely comfortable to very comfortable in assessing for a history of brain injury, which is great, right? Because if we know the prevalence is high, we want the screening to continue. And then we also asked them how effective they thought their interventions were um, with people with a brain injury. Again, the darker blue is before the training. And so people were feeling like it was somewhat too effective, but we again saw a shift that most, at the end of the training, most providers felt that their interventions were approaching very effective, which is great. Sort of saying that they felt more comfortable and that what they were doing was having better results. We also assessed how familiar people and comfortable they felt with using SMART goals. So again, before the training, it was mixed. After the training, people were definitely much more familiar and comfortable with using SMART goals. And then we also looked at the specific content areas or conditions that we looked at in those didactic sessions. So again, in all areas, we saw an improvement from before and after. Interestingly, we saw an improvement in areas that were not specifically addressed by our training. So we looked at trauma, which could be that providers maybe were doing additional learning and education to address trauma, or they felt perhaps in that more effectiveness piece that someone with a brain injury and trauma, I know how to more accurately address what their needs were. And then some of the more specific cognitive areas, such as attention and memory, cognition, those had sort of a 2-point jump on the Likert scale. So showing definitely a shift towards feeling like they could address those issues within their treatment sessions, which was great. So generally overall positive. And we also looked just sort of at their perspectives in general of the training itself, which again were positive and mixed. So, one of the providers noted that using sort of the more compensatory strategies was less interesting to them or less of a focus in their session, but they felt overall understanding cognition helped see how it all fit together. Other providers noted that they enjoyed having the concrete methods to target certain areas, especially when the client's presenting with a need. And some of the feedback was, having a more condensed version, which is definitely part of the lessons learned. So this occurred 8 sessions over a 6-week time. For busy clinicians, that can be a lot. And so we did have some issues with attrition. We didn't have as many providers finish as started, just because of the time that it took to get through all of the content. Providers definitely noted, and I think this is to help as we're developing programs carrying forward, there's a lot of increase in screening for brain injury in a lot of different community sites, which is great because we need to know it's there. But then providers really need to be equipped to address it, right? It's like, okay, that's great. I know that a history of brain injury is here, but now what do I do? And so this pilot model showed sort of the benefits of doing that together. We're going to train you to screen and then we're going to train you to address it. And that should inform how these programs grow in the future. We also learned from this that it was really helpful to build connection with existing community services. One of the outcomes was engaging more with the Brain Injury Association of Maryland, which really helped connect some clients who qualified for their services there. So we know that there's a screening for brain injury. We have this community resource, and being able to build those connections was really helpful. One downside to all of this is just being able to administer all of these screening tools. So as a federally qualified health center and HCH site, there's a lot of different screenings that need to occur to capture sort of all these different components that are affecting our clients. And so adding in another screening can be really cumbersome. Folks want to just get to the actual practice. Like, let me actually help you and work through these issues. I don't want to spend 3 of our sessions screening. And so just being mindful of that and when does this fit into the plan and the treatment program and where does it go along with everything else. And we found that we're not able to capture any data of the HUDAS 2.0 as part of the pilot training. There simply just wasn't, the 6-month period was actually not enough time to capture it. By the time the providers were able to administer it, maybe the client had missed a couple of appointments or they hadn't progressed enough that after 6 months it was a useful tool in administering. So although it's a good tool, sort of identifying when to do the pre and post and how does that correspond with treatment planning, and again, where does it look like in this population in this clinic setting. So although providers didn't think it was unhelpful, it was hard to figure out how to fit it in. So definitely something to be mindful of in the future. that's really the overview of the program. I'm just going to share a couple of resources for folks who are interested in learning more. Like I mentioned, the HUDAS is available for free online. That's the link posted there. The American Congress of Rehabilitation Medicine, which is where a lot of these strategies were adapted from, offers a 2-day cognitive rehabilitation training that folks can register for. So if you really want to dive into, several hours of learning about memory strategies or executive functioning, this is a really great training to be able to do that. If you're interested in screening, the OSU TBI ID is also a free screening tool that's available. Their website is pretty robust. It includes all of the forms, as well as extended online training, including demonstrations of how to administer the tools, related resources, and also all of the links to all of the publications and research that they've done on the tool is available from their website. And then just a couple more resources. So the National Healthcare for the Homeless Council has adapted clinical guidelines for working with people who are TBI and unstably housed, and these guidelines are available for free just by filling out a form there. And if you're more in the TBI world and getting used to working with people experiencing homelessness, they also have the guidelines for general recommendations for the care of homeless patients, which again helps to think about adapting your practice to making it more inclusive for people who may be unstably housed. And then finally, the last resource I'm going to share is Brainline, which has a lot of resources for practitioners, families, and individuals living with brain injury. They have videos, they have handouts, they have all kinds of stuff on there, so it's definitely worth checking out. All right, so I will pause there to answer any questions that there might be about the training, about the outcomes that we have. Happy to answer more.
Caitlin, thank you so much for this really informative webinar on and a very important pilot. So one of my questions is, if you were to start this pilot now, given COVID, the pandemic, what might you do differently, or what impact would it have?
Sure, yeah. I mean, I think one skill and one area really that is a big focus for any practitioner right now is thinking of the impact of telehealth on this particular community and how that would change how services and content are delivered, or how people are gaining information through telehealth. We know telehealth can be effective, but for some of these learning and teaching things like that are more hands-on, we would definitely need to adapt that to be responsive to the fact that telehealth is a big part of care. And for people experiencing homelessness, telehealth is not necessarily video, but it might be just phone calls. And so really I think that would inform a whole other set of strategies and how to do these things effectively, or even thinking about how strategies might be different, like the importance of repeating information and having the person summarize the information back to you because they can't demonstrate and you can't see their facial expressions or if they're paying attention. So I think it would inform really a lot of how the strategies were presented and how we would help providers use those strategies.
Great. Thank you. Thank you. One last question before we conclude. What would be a next step in a study if you were able to conduct another one?
Sure, yeah, I think a couple of things. One thing that did come out of this study was actually the ability to be involved in the development of the adapted clinical guidelines for TBI for the National Healthcare for the Homeless Council. So this pilot study sort of concluded at that time, and it was a good transition to be able to take this pilot study and use that to inform that document, which is a really great outcome of doing that. I think it would be really great to be able to do some more robust research into the effectiveness of the strategies. So they were based on evidence, but obviously modified because of the population. And there's very, very little research on interventions, often specifically for people experiencing homelessness. There's a lot of limiting factors in that, but we think they're clinically effective, but being able to have some research behind that to make sure really that they are effective in the way that we think that they are. would be a very large project, but even being able to do that for a couple of them would be really exciting. And to really have a manual for providers that they could use to sort of, again, guide and inform their practice.
Thank you. I want to just thank you in general for being with us today and for publishing in Work. We love this article. It was so informative and look forward to your future publications. So thank you so much for being with us.
Great. Thank you so much for having me today.